I think that the treatment of pain, especially in the acute setting, is particularly important. I think we're beginning to understand more and more how just the first couple of days after a surgical procedure or a physical trauma, how that pain management really needs to be treated optimally. That doesn't mean no pain, but treated optimally so that you decrease the chance of it transitioning into a persistent post-surgical pain or a persistent pain after a medical condition or after a physical trauma.
You're listening to Pedia Pain Focus, episode number 48. Today, we discuss what best pain care everywhere means and looks like, how and by whom it can or should be accomplished. So, stay tuned.
Pedia Pain Focus.
You're listening to Pedia Pain Focus, brought to you by Proactive Pain Solutions. Pedia Pain Focus highlights pediatric pain information and provides tools and resources for all healthcare professionals taking care of children dealing with pain. Here's your host, Dr. Anjana Kundu.
Hello, ladies and gentlemen. Welcome to Cafe Pediatric Pain Focus. I'm your server, Dr. Anjana Kundu, where on the menu is a delicious episode, Best Pain Care Everywhere, with Dr. Tracy Harrison of the Mayo Clinic. Seriously though, this is a fantastic episode where Dr. Harrison delves into the issues of how we equipped our clinicians, its implications for clinical practice, impact on the healthcare, the role various clinicians, clinical services, and institutions play, as well as how these best practices can and should be made universal. Now, this is an episode so close to my heart as the very foundation of our company, Proactive Pain Solutions, is making access to expertise and high-quality expert pain care possible for all involved. And you, my friend, if you're thinking, I already know this stuff, or maybe you are in the "it's not my job, the pain service does that" camp. Now, just you stay with me. Stay and listen how she is going to revolutionize. Yes, that's right. Not just change, but revolutionize your thinking about the issue. And even more importantly, she will give you practical steps you can start implementing tomorrow, or heck, today, if you're listening to this, depending upon what time that is. It's funny that I start out addressing her by her first name, and later on in the episode, I switch back to addressing her with her professional credentials. That's possibly because I've known Dr. Harrison for a very long time, and that's probably why I started on that personal note. I had an opportunity to facilitate her training during her pain fellowship with us at Seattle Children's Hospital. And she had spent several months with us to get her pediatric experience there. As a matter of fact, she was actually our very first pediatric pain fellow to have been through that program. Now, I say facilitate because that is the correct word, for I knew that Dr. Harrison is an absolute rock star from the moment I met her. She is one of the most thoughtful and committed physicians I know. I feel she taught me, and today too continues to teach me, just as much, if not more, as I had the ability to contribute to her learning. Now, just a little bit about Dr. Tracy Harrison for your benefit before we dive into our conversation. Dr. Harrison is a board-certified pediatric anesthesiologist, pain medicine, palliative care, and hospice care physician. She's an assistant professor in the Department of Anesthesiology and Perioperative Medicine at the Mayo Clinic in Rochester, Minnesota. She is a co-director of the Pediatric Pain Rehabilitation Center that treats some of the most complex chronic pain patients who are significantly disabled by their pain. And these patients come from all over the globe. She has many publications to her credit and is an invited speaker at national and international pediatric pain meetings. She also chairs the Patient and Family Advocacy Council at the Mayo Clinic's Children's Center. So let me not keep you from talking to Dr. Harrison herself. All right, let's welcome Dr. Tracy Harrison. Tracy, it is so wonderful to have you on Pedia Pain Focus. Thank you for taking the time.
Thank you, Anjana. It's my pleasure to be here.
Hey, Tracy, I've had the pleasure of knowing you for a very long time, it seems like now, and what a joy it has been. And it's been fantastic to see your journey, your development, and all the amazing things that you've done. It's been wonderful to follow that. But it'd be lovely for my audience to hear from you. Tell them a little bit about yourself and what made you interested in pediatric pain.
So I did my anesthesia residency in New York City at St. Luke's Roosevelt Hospital Center and came to Mayo to do my pediatric anesthesia fellowship and was given the opportunity to be part of expanding the acute pain and chronic pain services at Mayo Clinic and jumped at that opportunity. I did my fellowship here, and I guess the rest is history because I've now been involved in numerous different activities and aspects of pain, from acute pain all the way up to palliative care. And it's really been enjoyable to interact with individuals like yourself and others, experts in pain management.
It is a wonderful little community, and obviously the joy is mutual, Tracy, so it's good to have you here. But listeners, Dr. Harrison has been doing this since, when was it the first time we met? Was 2006, was it?
It was, 2006 at Seattle Children.
Seattle Children. So it was a pleasure. And since then, I've just seen you blossom and lead an amazing program at Mayo, which is, obviously something that everybody looks up to. And we refer patients there all the time. So thank you for doing such an amazing job. Part of this, Tracy, is that I know your passion for pediatric pain. You are a big advocate for standardized or excellent care everywhere for all children, right? Regardless of where they present. And I'm sure we all have our own drivers for thinking that way. But I just would love for you to expand a little bit. What made you think that there was discrepancy, and why do we need to actually vocalize and take up this cause of best care everywhere for children?
So I think you can see, if you look in the literature over the last number of years, that there is mention about the disparity of pain management treatment, say, for example, in different groups. So there's some racial disparity. There's also some age disparity. So it's difficult to measure that. It's complex, but I think you will see some evidence of that in the literature. I think also, as I've heard on your podcast and other researchers have talked about, the fact that, pediatric pain management has come a long way in the last 30 years or so. Mm-hmm. And although we know the different treatments that can be very, very beneficial for pain, the truth is that prevalence of acute pain in a hospitalized setting or in any setting remains high. I believe that some individuals are doing very, very well when it comes to making a good plan, comprehensive plan for their patients. And I think other individuals and services struggle with that. So that's kind of what I'm talking about. And I think I've seen that in my own institution as I've kind of looked at different things. We all practice in different ways. Mm-hmm. And that's what makes me feel that there is a disparity and that there are improvements. That's the good news of it.
Right. And I know, just to clarify, Tracy, I know you don't mean discrepancy between individuals in the same, say, pain service. You mean at an organizational level, like in what part, depending upon what part of the hospital they present at, they may get different degree and level of pain care. Is that true?
Yeah, and I think there's a clarification, because when I talk about disparities, I think the pain-trained physicians and providers have gotten that kind of background. And I think it's probably true that many of the pain physicians actually have a systematic approach, even if it's not written down. They have a systematic approach of how they do things. Mm-hmm. What I'm talking about is more the individuals who are not specifically pain trained, mm-hmm. who are the pediatricians and the surgeons. And I mean, they came into medicine to take care of children or to perform surgery. And pain is something that every patient is going to experience, mm-hmm. but they are not necessarily pain experts. And we've talked about, and I think you've talked about in your podcast too, about that real lack of pain education in medical schools, right? The fact that, you even quoted it that veterinary students get maybe 5.5, 6 times more pain training than medical students do. So there are different things I think that contributes to that. I hope that clarifies.
Absolutely. Absolutely. I know it's obvious when we talk about pain that we want to do a good job of managing pain, but I know there are bigger implications than just that. So what are the implications when there is this discrepancy that exists across different parts of the institution, or even geographically, depending upon where, the children, what state they might be living in or what country they might be living in?
I think that the treatment of pain, especially in the acute setting, is particularly important. I think we're beginning to understand more and more how just the first couple of days after a surgical procedure or a physical trauma, how that pain management really needs to be treated optimally. That doesn't mean no pain, but treated optimally so that you decrease the chance of it transitioning into a persistent post-surgical pain or a persistent pain after a medical condition or after a physical trauma. So that's a huge burden to society. I know you're very, very involved in chronic pain, and it's a significant impact on financial stability, patients' ability to go to work. But for children, it's, their parents need to be home for them. So it has a large implication in that way. I think another big aspect of it is that from what I've seen, looking at different patient comments and things like that, just to kind of get a better understanding, I think there seems to be a discrepancy in how much a physician and provider really cares for their patients and kind of what those patients are kind of understanding. So every provider wants to do best for their patients, right? But sometimes when we approach pain management in different ways, we don't necessarily convey that care for them. And it's challenging, admittedly, right? And so I think sometimes patients walk away from an episode like that and they feel like they're not heard. And that causes some mistrust or fear or anxiety, which may be pre-existing. And I think that there are some mechanisms that we can use, that every provider can use who takes care of children or adults in every capacity can use to be effective. I think that's what we need to encourage, is that these are different ideas that we can teach and we can learn and do better with.
Right, absolutely. Dr. Harrison, you just said, obviously, one of the biggest reasons is how we lack training, a proper training in even the basic pain management skills across medical disciplines. Are there any other contributors that you see, whether they're system-wise or otherwise, that may be contributing to this level of differentiation in how a patient is cared for across their healthcare experience?
First of all, it's really difficult to measure kind of how well you're doing. I think one of the challenges is that with the idea of pain scores, they're not perfect. So providers have often gotten themselves into some trouble when they're kind of chasing pain scores to make them as low as possible, right? So I think the whole idea, for example, about the opioid crisis, while paying attention to the very important practice of making sure you're giving the minimal amount of opioids, or you're trying to avoid opioids when you can, that's very respectable. And I definitely am a big proponent of that. But I feel that often causes many providers to feel that they are very much scrutinized by different individuals or different bodies. So the whole opioid crisis bit is a little bit of that. I think another aspect of that is that sometimes even though we wouldn't say this out loud, we almost settle for like good enough. In other words, kind of what's the evidence that my pain management practices are not good? And I think that's really, really challenging to kind of pull up because there are so many subjective factors, right? The whole idea about pain is a subjective factor on its own. And then the various emotions that parents and their children come in to a hospital setting with, it can make a difference. But I think it's that sometimes that willingness to say, how can I do better? How can we do things differently? Because we all find it difficult to make some change. So those are a few of the contributors, I think, that warrant a better look at or being reflective of what happens in your own practice.
I think the reflection of how, like, what is good enough, what isn't, and also balancing that with, as you said, are you just simply checking the boxes or just so that you can check off the boxes given to you by regulatory agencies, whether you are treating a number or whether you're responding to that or not. And I think what you bring up is an absolutely critical point, is that whatever we do, regardless, that introspection is what's going to drive better care. So thank you for that clarification and those wonderful ideas. Obviously, we've sort of been implying in our conversation that a child deserves care, best care everywhere, regardless of where they are. But is there obviously when we say do everything, nothing gets done kind of, right?
Right.
So if it's everybody's responsibility, it's nobody's responsibility. So do you think there is a area or section or division or person or people that are responsible for ensuring the quality of care that everybody should receive? Does the responsibility lie with somebody in particular, or is it truly everybody's responsibility? And how do we balance that?
Mm-hmm. Yeah, I think that's a really good point about everybody's responsibility or no one's responsibility, because I think oftentimes non-pain specialists, for example, pediatricians, surgeons, and I don't mean to pick on them, I'm just using them as an example because that's kind of what is in my experience. Those are who I work with. They know that pain management takes some thinking, and they know that individuals go through training. But I really think we need to kind of change that focus, that really every provider who cares for children, who sees children, needs to take some responsibility. And I think that's what I've kind of gotten from your podcast. I mean, I think that you are really trying to reach that group to say, we want to teach these different strategies to allow you to be a good provider, even if you're not going to go do a pain fellowship tomorrow. But yeah, I think it's everybody's responsibility. And I think it's easy enough to do it in some way. For example, like this, I just went upstairs to go see a patient who I had taken care of yesterday for an anesthetic. And I asked her and I said, is everything going fine? Do you have any questions or any concerns? Now, I wasn't representing the surgeon per se, like I introduced myself as the anesthesiologist, but I think we have a responsibility to be acting as a cohesive team with other individuals. And if we did see that a patient was having some difficulty with pain or with anything, it warrants an acknowledgement of that. And then going to seek out, hey, I'll find your nurse to see if he or she can help, or I will pass this on to someone else. So I think I think we all have that responsibility, even just to check in with someone to say, hey, are you okay with how things are going? Like, how is your pain? And you can do that in a short period of time. I don't think it takes a very, very long time to do it. And you become familiar and more comfortable with it over time. I think, there's no judgment here, right? We've all been in a position where we didn't know what to ask somebody about pain, right? When we were medical students or when we were early residents. So there's no judgment. It's all about how can we learn from each other and learn from kind of what the patients are telling us in one way or another through their actions or through their just
expression, their input. Yeah,
absolutely.
Yeah. No, that is very, very true. And to be honest, as you bring up another of course, you bring up great points regardless, but another good point is that we don't have to feel fearful and or embarrassed or judged or anything about if you don't. There is no shame I say this all the time, no shame in saying, I don't know, but I'm willing to find out.
Absolutely.
And that is actually, as a matter of fact, a big part of pain management because there's so much unknown still, especially with chronic and complex pain. There's so much that we're still discovering, that's so much that needs to be discovered. So there is no harm, no foul in saying either we don't know enough about it because that's where things are, and or just saying, hey, you know what? I don't necessarily have a lot of experience with that, but I know I'm willing to find out. I'm willing to send you to somebody who does. And it's okay. And that's all they need to hear because people, I mean, we're ultimately human beings, right? All we want is that
Absolutely.
validation and recognition and that we're heard. So I think that is fabulous. Dr. Harrison, I know you say, obviously, we all have a responsibility to, at bare minimum, ask about what their pain or comfort level is and what might be bothering them. Then we're obligated to do something about it. But is there a role for preemptively doing something ahead of time? Are there things that we could do ahead of time to even avoid that circumstance of trying to chase your tail and later on trying to figure out what's going on? Especially for pain management, I know there's the concept of preemptive analgesia. Obviously, how do you balance that preemptive analgesia and the safety of doing something? Especially, as you know, opioid crisis scares a lot of people. And that is a really great example of balancing preemptive analgesia versus safety in the treatments that we're giving. So do you want to elaborate a little bit on that?
Absolutely. I think that's such a fantastic question and point because I think there's always room for us to do better when it comes to preparing patients all along the way. So I think, for example, I always try to get an idea if patients have been told by their surgeon, for if they're having surgery, what their pain management experience is going to be like, the intensity of their pain, and then also whether or not they've been told, communicated about a plan that is going to be in place, whether they're in the hospital or afterwards. Because I think to be able to talk about, I think avoiding talking about that kind of implies to someone like, oh, they didn't talk about pain, so I'm not going to have any pain. And I think that can then set the patient up for a lot of unrealistic expectations that we're then now kind of chasing their satisfaction after that. And then of course, I think the idea of preemptive analgesia, right? I mean, as it comes to doing non-opioid strategies, right? That's why we give acetaminophen before a procedure or before a surgical procedure. And those types of things that we do with anesthesia, that's kind of trying to get a head start on that pain management. I think a huge part of it is also, I'm a big proponent of looking at different procedures and seeing whether or not those particular procedures are associated with mild pain, moderate pain, or intense pain. And then you kind of set the stage for what the plan is going to be based on that. And I think that then takes away some of this either emotional component or some of the other components that can be challenging, right, that can contribute to pain and discomfort, like, anxiety and mood issues and things like that, right? I mean, we would treat those types of things in different ways. I mean, we wouldn't give an opioid for that. So yes, that whole idea of preemptive analgesia, kind of getting medication to the pain generator, if you will, before that pain is really generated, right? To decrease that chance of central sensitization, kind of getting a foothold, which is then, what is often thought to drive into that persistent post-surgical pain. That preemptive strategies are very beneficial and can have a great impact.
Right. And as you said, they extend beyond medication. They can be simply allaying their anxiety about setting their expectations right and all that. So it's not all about medications that are given preemptively, but it's also how you prepare and what you set them up for. Perfect.
Absolutely.
I can hear the audience saying, these are great thoughts and ideas. How do we put them in practice? Are there barriers that you see that exist to putting such a great plan in place to make sure that all the kids are getting best pain care everywhere.
Yeah, that's another part of all this that I think is really fascinating and very interesting, because I think, for example, our electronic medical records might be in a position to guide a lot of that pain management. And I was hoping that that would direct that management into a more systematic approach, but that has, I think, shown to have some barriers. So again, while many individuals have done a fantastic job of curating a systematic approach and a menu item for things that they can choose for a particular procedure, it's not necessarily across the board in all different specialties or different hospitals and whatnot. And interestingly, as physicians, as medical providers, we oftentimes will think about the medications, but we really don't think so much about the non-pharmacologic strategies, right? Like the ice and the heat, but then also like, how do we keep a child occupied? Children are bored. Like, do they like to do art? Do they like to music therapy? Do they want to enjoy pet therapy? All of these things. And that's what, going back to what you had said before, it's almost like no one's responsibility, because a physician or a healthcare provider might say, that's not my job to order the pet therapy dog. But you know what? Maybe we should start to think about that a little bit more, that us as medical providers making a case for the importance of those non-pharmacologic strategies that are low risk and are often very easy, or relatively easy to roll out and of little cost, can have a big impact on making people feel like I like to say, getting back to the land of the living after surgery, right? You want to get back into enjoying those things that you like to do. And when you're in a hospital bed worrying about your pain, it's really, really difficult to do that. So those are some of the things that are barriers into who's kind of responsible for making sure that the whole gamut, if you will, of strategies are available and are implemented.
And as you said, when they are out post-surgery, as it is, especially children are out of their comfort zone, they're not in their environment, it becomes even more important to try and make them feel some sort of comfort and something familiar or something that they can relate to. And those kinds of things, as you mentioned, the non-pharmacological things will go a long way in that situation. Absolutely.
I just wanted to say one other thing about that, because I think that also has a secondary effect, that if a medical provider, if that's coming from a medical provider, that really can do a lot to allay the anxiety of a parent that is there at the bedside, because they're thinking, oh my God, how am I going to take my child home? And where they have so much pain. And I think if we can start to model to them that some pain is expected, right? And that sometimes we can make a little bit more of our pain because of other reasons, right? We're distressed. We're not sleeping in our bed. We don't have our teddy bear with us. But if they can see us model some of the ways that the children can get back to life, I think that can allay a lot of the anxiety parents have, which we know children feed off of that, but they can also feed off that calm as well, right?
Absolutely. Absolutely. That's a really great point you bring also. And as I'm sure you heard the episode we did on Manage Memory, Manage Pain, a lot of that was how you can help parents help change the entire experience of a child's pain around a painful experience, and even their future expectations and experiences, by simply how you talk about it or how you just absolutely manage the expectations and the experience around that very painful experience. So, and it falls on everybody. So we, as you said, you show the parents how they can change their child's entire pain experience, and they feel empowered by it as well, that they can do something.
Exactly.
So how does one go about the therapeutic interventions, whether they're pharmacological or otherwise? But is there a system that you use or that you recommend that we can perhaps all follow, or we can recommend to others that they can be doing it as of tomorrow?
So I've actually been thinking about this for a long time, and I think I have a library full of these various articles that I kind of look at as the milestone articles that really show the way that I want to practice and that I've seen successful providers practice. And so I try to have this very systematic approach where I develop a template so I can kind of follow that, and I distribute that to our fellows, our pediatric anesthesia fellows. And I thought this was so interesting to address because there's no very easy way to implement that at the bedside. And so I'm actually working on the development of an app that will exactly do that. And you can use it at the bedside. And it should only just take a few minutes from things that you know from the patient, but you will just answer these particular questions, and they will give you, the app will then show various options to be considered or not to be considered, right? And then on the back page, you will have a plan that you can then go ahead and follow. And I think the importance of this is that it will actually allow or encourage providers to think about all of the complex variables that can go into making a plan. For example, thinking about stool softeners, thinking about what do I do if I anticipate a patient's going to be nauseated. Just even thinking about that will allow you to give that better care and will give you a mechanism to be able to talk to patients. I mean, I think it will be an educational tool in its own. So that's something I'm working on and something I hope to be beta testing pretty soon, and we'll be looking for people who are interested in that, and specifically non-pain specialist providers, right? Because this is catering to those individuals who want to tomorrow to be working on improving their pain management delivery.
Oh, that's lovely. I'm sure people would love to have access and be your beta testing partners. So whenever that's available. So we would, if you let us know, I'd be happy to amplify that message to people. And of course, we can include your information and people can get in touch with you as well and keep in touch and find out when exactly this is going to be available to them. Is there something that you can share today, like even general approach that they can take?
Sure. So, as I said, just having that conversation about the intensity of pain that you expect someone to have. And you can say things like, we expect that you will have some pain. We can't promise that you will have zero pain afterwards, but we promise we will do everything we can to balance that safety and your comfort. I think making that statement really can make a big difference. And I think that's even been shown in research studies that itself will help. That improves patient satisfaction. So the other thing I do is I really talk about the fact that what is the goal of pain management? Pain management isn't necessarily to make the pain score zero. It is to make you able to participate back into those activities of daily living, that you should be able to rest with some periods of comfort there, that if you're eating, you should be able to, and make sure, focus on your eating, right? Because so many patients after procedures will say, I don't want to eat. So I say nutrition is really important, but really working on those non-pharmacologic strategies and from the beginning, right? I mean, at the same time that you're giving the non-opioid strategies like the acetaminophen and the ibuprofen, if it's appropriate, you're at the same time, you're saying, what are the things that you enjoy? And you say, this is part of pain management. This is just as important as medications. Then there are other steps to consider. And I think documentation of all of this is really important because when you feel as a provider that you must give an opioid, then you can have much more power behind you if you say, we have optimized all of the non-opioid strategies. We have encouraged the patient and communicated that function is the most important thing. And in order to achieve that, we feel that we need to provide some opioids and reassess that on a daily basis or even more frequently. And I think we will really find providers more confident about their ability to provide opioids and good pain care, comprehensive pain care. And I think the patients will appreciate that communication.
Well, that is very, very true. Well, thank you for that wonderful systematic way to approach. You don't have to know exactly what medication to give, but how you approach is the most important part that we can be playing in it. As they say, preparation is 75% of the battle won. So there you go. Dr. Harrison, what advice would you give the healthcare professionals who encounter any amount of pain related to their patients, as well as anybody who's actually specifically doing a pediatric pain management, so they're pain specialists already trained?
So, I mean, as we've said a bit during this discussion, is that I think it's important to have a conversation, even if it's a brief conversation. Just check in, how are things going? Because I think asking that question acknowledges that the patient might be struggling in some way or having pain or having other things that are contributing to their discomfort, and really asking, and not in just kind of a rote way, but just saying, what specifically is bothering you, so that you can kind of understand that. I think that having that communication is really important, but I think it's also important to ask other individuals, right? I mean, that's why we're here as pain specialists. We oftentimes enjoy getting those curbside consults if it's allowed in your particular institution. But I think it's important to maybe get another idea from individuals about what they might do in that particular way. Mm-hmm. I think it's also important to again, clarify the whole idea about functioning and give those patients those kudos, right? When they say like, oh, I'm still having pain, you can validate that. And you can say, of course you have pain. Like, we just did this large spinal surgery, and give them those kudos for, you did such a great job up and out of bed to the chair. And my goodness, it's so difficult. You're working so hard on this. Because I think they really need that, and that will make them feel good. And I think it will allow them to trust you a little bit more with your care, and give them the message that you do care about them.
Mm-hmm. And what kind of special responsibility do pain specialists hold? What can we do to enhance this better pain care everywhere throughout the institution?
So I think honestly, we can do similar types of things that you're doing, right? I mean, you are putting your information out there, and for all providers to have that access to, if they're interested in that. And I think they can probably take away one little tidbit of information from every podcast that they listen to about pain, or, following somebody on Twitter that, is going to be talking about pain. Mm-hmm. I think another way that we can be effective is that we can demonstrate to our colleagues that we're really out there for them. Of course, we would always be open to a pain consult if they felt that they needed to formally consult us. Mm-hmm. But I think we also have a responsibility as pain providers to provide education, maybe, different grand round sessions, express that interest. And even if it's in a more or less formal way, express that interest in giving non-pain specialists some of the good advice and some of the basic principles that we work on. Mm-hmm. Honestly, I think the struggle that we get into is that as pain providers, or I should say, as non-pain providers, some individuals feel that pain management isn't within their responsibility, and there are just simply not enough pain specialists to go around. Mm-hmm. And I believe, like I had said at the very beginning, I think it's the responsibility of every single one of us that see children, or any patient for that point, to check in with them about their pain and do what we can to make some of those improvements.
Got it. Well, thank you. Dr. Harrison, I'm sure people are going to want to get in touch with you. So what is the best way to get in touch with you? What's your best contact information?
So I'm on Twitter, and my handle is at Dr. Tracy Harrison. And I'd love to be engaged in a conversation about other people's interests, their experience with pain management. Because, we learn, that's another thing, Dr. Kundu, right, is that we as pain specialists, we learn from the non-pain specialists. We learn from the pediatricians about their experience and the challenges that they have. And that allows us to do better as well. So I would love to be involved in a conversation with that. And Dr. Kundu, I just commend everything that you're doing here on Pedia Pain Focus. And I've really enjoyed our conversation today. This is really good work you're doing.
Thank you so much. And I can't do this work without amazing colleagues like you who are willing to share their expertise and are willing to help improve the care that children get everywhere. So thank you so much for being here. And I love this information. Like I said, can't wait to see all the other amazing achievements that you're going to make, because it's been lovely to follow your trajectory, and can't wait for your app.
Thank you, Dr. Kundu, very much.
Thank you
much
so
appreciated.
much. Have a lovely day.
Thank you.
So there you have it. Wasn't that just incredible? Didn't I tell you what a rock star she is? Not only is she thoughtful and committed, she is passionate and innovative as well. I, for one, can't wait for her app to be available and be put in practice by everyone, so all these children and families can get the care they deserve, and for clinicians, they can have the tools they need to be able to give the best care possible everywhere. Now it's your turn. I would love to know what resonated with you today. How do you feel about this issue of best care everywhere? Let us know in the comments, and let's start that conversation going. Also, if you found this episode useful, please share it with someone else who may benefit from hearing this information as well. And if you can take a little time to review our episode and our podcast, that would help tremendously, because it gets it in front of more people that need this information, perhaps even more so than you. And of course, we here at Proactive Pain Solutions will thank you, as will those people who will see it because you took the time to review the episode. So thank you, friends. I will see you in 1 week's time with another fantastic guest, Dr. Rachel Coakley. She is a pain psychologist at Boston Children's Hospital who has done incredibly innovative stuff, and we will be talking about one of her innovations, the Comfortability program that she has now being adopted over 21 sites. So don't forget to join me next week. Until then, stay safe, be proactive. Bye now. Pedia Pain Focus is a presentation of Proactive Pain Solutions, a company committed to transforming pediatric pain care through improved access, quality, and expertise. Did you know that there are only 4 accredited pediatric pain medicine training programs in the U.S.? Meanwhile, there are 19 million children that suffer from chronic pain. This means the children's pain care is largely left in the hands of untrained healthcare professionals. This large gap in children's pain care leaves both the healthcare professionals as well as patients and families frustrated. Data clearly shows that untreated or poorly treated pain in children leads to a much higher incidence of refractory chronic pain that lasts into adulthood, much higher incidence of mental health diagnoses, and a massive societal burden. It also leads to poor job satisfaction and poor job security for healthcare professionals. Proactive Pain Solutions Physicians Academy is the answer to this major problem, eliminating that large gap through our comprehensive evidence-based virtual training program that's bolstered by live Q&A sessions, personalized mentorship, and leadership development. The limited time enrollment is now open, and it offers a limited number of spots. So join our academy today and know what it's like to have the expertise at your fingertips while you enjoy the professional satisfaction and the job security that you deserve. Join us at www.proactivepainsolutions.com.